Welcome everybody to a really lively discussion between really dedicated leaders in the field of HIV and AIDS that have been at the forefront really for decades, understanding how to bring communities and policymakers and funders together in a new and innovative way that results in really listening and acting at the community level. We all have watched the last 3 years and the impact it's had on our progress with HIV. And we had a really great alert coming out of UNAIDS to really tell us about where we are, and new strategies coming out of WHO and new strategies coming out of PEPFAR, and really an incredible global fund replenishment and hopefully reauthorization of PEPFAR within the next 12 months to really ensure that there's funding to really execute. But it's really my pleasure today to have with us 4 incredible leaders in the field. So Meg, what do you think is critical to the global HIV response in order for us to control this pandemic? And what do you think the key focus needs to be at the country level? And what efforts have to be redoubled to make sure that we achieve our goals and not sit back and say we've done a great job?
That's a great question, and I'm sure everybody will have their views on this. But what is important in this time in 2022 is over 2021 and 2022, we have this sort of synergy of all the different strategies that are available. So there's no confusion. The UNAIDS strategy, the Global Fund strategy, the PEPFAR strategy, our own global health sector strategies on HIV, hepatitis, and STI really have commonalities across. And I think all of them speak to, number one, person-centered care approaches and working towards inequalities, inequities. And each of the strategies tackle it a little bit from different lenses, such as the UNAIDS strategy, under which we all work around inequalities and reducing those, not just the 95-95-95, but the 10-10-10, and reducing stigma and ensuring that there are no criminalizations as well. But then there's precision prevention coming out from Global Fund, sustainable non-stigmatizing care from PEPFAR, and I think from WHO, we have all of them, and we've also taken this added lens of saying there are commonalities and starting to link that to what are the commonalities across the 3 diseases of HIV, hepatitis, and STIs, and what are the things that we can do that will lay a founding groundwork for things like primary care. Because I agree with you, we did really well because of the community approaches and that commitment. But I agree with you as well, we haven't strengthened and bolstered primary care to be able to withstand the next pandemic. So for us as well, we've taken, at least for this World AIDS Day, we want to remember 2 groups or a couple of populations. We're focusing our messages around key populations. We have new recommendations, new guidelines that are out. We know that the data show us that not overall 70% of all new infections are happening in key populations or their partners. And then if you go to some countries that are starting to see inclines in new cases, it could be up to 90% are happening in key populations and their partners. So we've somehow forgotten that we have a big key population challenge, because there's so much stigma and discrimination occurring, so many polarized views. We at WHO says we need to work with all populations: men who have sex with men, transgender people, people who inject drugs, sex workers, people who are in prisons. And we also want to work with children and adolescents and mother-to-child transmission as a way to say we have a litmus test for elimination. If we can also move and take care of all those children who've been left behind, a smaller number, but if we're able to do that, then I think we'll be able to show that in all populations we can reach those who have been left behind in different programs. So from us, I think I always talk about the bookends. We want to use all the new innovations on the end of reducing new infections. HIV self-testing has been super important. It has moved us to doing COVID self-testing, hepatitis C self-testing, syphilis self-testing is on the way. And I think we need to do more self-care. We want to see PrEP utilized, whether oral PrEP, long-acting PrEP. We have seen some really exciting data coming from countries that have introduced treatment for everyone, plus PrEP, that we're starting to see in cities, 0 new infections in key populations. This is Amsterdam, this is London. How can we replicate that 1,000 times, 100,000 times over? And we also want to address the late stage. We don't want to forget advanced HIV disease and re-engagement with care. So I think to be able to do that well, you need the continuum of care, but innovations and also addressing some of those real structural barriers that have not allowed us to work with key populations in all of the world, because those are the populations that actually have to have the services accessible at all times. So I've covered a lot of areas, but let me not dominate the conversation and pass back to you. I'm sure we'll come to some of the other questions as we move on. Thanks.
Meg, brilliant points. And thank you for also raising advanced disease, because, I've watched the median age of our HIV cohort go from 30 to 40 and approaching now 50. What does that mean to me? It means that people are very motivated to stay on their treatment and to stay in their programs and are coming back and are being seen. But that comes with another set of responsibilities as program managers to really address what you really talked about, is the person-centered care. Because person-centered care of a 50-year-old is very, very different than person-centered care of a 30-year-old. And I really appreciate you talking about testing as a gateway, because I think viral infectious diseases outside of HIV and hepatitis have really not been tested for. And I think showing that self-test work gives us the ability to really empower communities to have their own gateway to treatment and prevention by having their own ability to know their status as a personal piece, particularly when we get to key populations and the level of vulnerability and stigma and discrimination. And I think that just raises such a critical point. So Regan, UNAIDS has really been at the forefront of raising the alert of where we are off track. I think it's a perfect time to raise the alert, because we do have 6 or 7 years to really ensure that we're meeting that. I think the piece put out on danger was so important. What does UNAIDS see as our key takeaways in getting us back on track?
Thank you. And it's great to be here with all of you. And Meg, thank you for those points. As a 55-year-old woman living with HIV, it's a long journey in life. And, it's so critical to think about the whole arc of it. So thank you for that. It is a moment of reckoning in the response. We've had many inflection points and we've made a lot of progress, but we put out that report in the summer because we are not in a good place. We are not reaching all the people that you've mentioned, Ambassador, and we need to find them and reach them. And it is inequalities that's keeping us from getting to them. And I just want to paint a little quick picture. I know everyone on this call knows it, but the compounding crises of more than 2 years of COVID-19 and the war in Ukraine, their combined impact on the global economy have really undermined our efforts. And we've got energy, political will, and funding understandably diverted from HIV. So we're operating in a much more complex world and people are not near their services, which is making it more challenging for all of us. So while the progress is slowing, we're also seeing an incredibly chilling human impact. And we all know this, but every minute in 2021, a person died of AIDS. Every 6 minutes, a child died. It's happening all over the world. Asia Pacific, Eastern Europe and Central Asia, Latin America, the Middle East, North Africa have all seen increases in new infections. And we had 1.5 million new infections in 21, which was 1 million over our target for 2020 of no more than 500,000. So we are really not in the best place. And we know who's most impacted, right? The adolescent girls and young women, gay men and men who have sex with men, LGBTI people, children, sex workers, they all face disproportionate risk. So the barriers are, as they have always been: stigma, discrimination, criminalization, political inaction, insufficient funding, and really inequality. And as you started the conversation saying, it's every type of inequality that's driving the pandemic, perpetuating it, and the pandemic is exacerbating those inequalities. And of course, people have intersecting and overlapping inequalities, and they change when their circumstances change. So it's a moving target, but a complex one, which is why, as you've said, and Meg pointed out, we have these strategies focused on the inequalities. So while we put out the call in the summer saying that we're in trouble, our World AIDS Day report is really focused on, so what do we do about it? How do we move the needle? How do we advance progress? So a couple of the things that we're looking at doing next year, and some which we've already begun with co-sponsors, including with WHO and others, we're focused on children. So next year, we're going to look at the ways in which we can most easily find the children who we left behind and get them treated and get them tested early. We're missing kids too much, too early in their lives. And of course, that is all preventable and it's all avoidable. Adolescent girls and young women, we are also continuing to focus on them. And we have a new global strategic initiative called Education Plus, which focuses on keeping girls in secondary school. It's a high-level political advocacy effort, which builds on some work that you've led and others are doing in the field on education for young women. But of course, by keeping them in school, we protect them from HIV and GBV, and there's a bidirectional impact with both of those things. We also need to protect them when they get out of school, but by giving them the life skills and the empowerment and the education, we hope that we send them off into the world in a different way. And then gay men and men who have sex with men, transgender people, sex workers are all facing legal environments which really keep them from accessing the prevention and the treatment that's going to save their lives. So we're going to be working with UNDP and others next year on decriminalization. We know the landscape around the world. We know where the policies and laws are bad. We'd like to look at opportunities and places where we can move the policies or remove the laws so that people can feel comfortable. It's hard enough to go to the doctor, let alone if you feel that you're going to be stigmatized, discriminated against, or criminalized or killed. These are the barriers that we're facing. So we know that if we approach these inequalities in a new way and we remove them, it's not an ideological thing. It is a good thing for the world to do. It is the right thing for people to do, but it is also how we solve pandemics. And if we do this for AIDS, we'll set ourselves up better for handling the pandemics of the future.
Thanks, Regan. I think for many people who aren't in the HIV/AIDS field, they don't realize how important the UNAIDS data has been in really giving us always that clarity of who we're missing, and then really focusing us on examples of people who have found the solutions. And I think, what you talked about of treatment and PrEP is just so extraordinary, because showing that there are cities that are achieving gives us the hope and the roadmap. Yes, it has to be adapted. Yes, it's different, but I think we're more alike than we are different. And I think that we can hold ourselves to that solution-based approach. But we are privileged because from the beginning, the granularity of the data has allowed us to focus on what we need to focus on and to really move policy and to move new ideas forward. And I think I just feel privileged to be part of a pandemic that put people and data at the center so that we could really understand not only who was showing up, but who couldn't show up. And I think that is missing in many pandemic responses. And I just thank you for highlighting the importance of treatment and prevention, because obviously testing is the gateway to that, and knowing your status and really making sure that you have access to both those services. And I think that's something that's often missing in the COVID response. No matter what the income of the country, we are not marrying testing with treatment and prevention so that people can get the options that they need that really meet their needs. And it's different as we age and where we live and what we want to really be focused on. And I think programs that are adaptable to the full range of the human experience is just so important. And so we always point out and we rightly so, of how disappointed we are in our progress. But I think we do provide a roadmap of really how to integrate and put this person-centered approach that Meg talked about. So Solange, you're really at that fulcrum of who's missing, and this 70% of new infections in key populations and their partners, just a really difficult issue when you look at the legal framework and the community frameworks in many of these countries. What solutions do we need to really close that gap for access to testing and treatment where people feel safe accessing testing, feel safe accessing prevention services, and feel safe accessing treatment?
Thanks for the question, and thanks for inviting ITPC. Thanks for inviting me. I think, as you point out, the outlook for key populations is embarrassingly disproportionate, right? We have even more recent data from our community-led monitoring in Malawi that compared access to testing services before COVID and then during COVID. And we saw that the largest gap was among female sex workers, and the testing fell by almost 80%. Key populations, as they are known, I think we need to remind ourselves they're key pops. We kind of just call them that, but remember that they are the most affected populations, most affected people groups. And I have sat on this question for quite some time, and really, what makes them more affected than others? I would argue at the core of it, it's because HIV is a moralized disease. And the gaps that we persistently see with specific groups of people are less due to medical, clinical, scientific, and molecular issues, and more of human rights and political issues. And I think to close these gaps, we need to work on the political levers to alleviate stigma and access. My strong belief is that we too often comfortably sit inside of our little echo chambers and listen to our results of our research and what we could do to make some sort of incremental change on, but is that enough? And don't get me wrong, I don't think that, I'm not saying that research is not important, but we really need that much more evidence to address these access gaps? And maybe if I could put it a different way, do we think that in countries with punitive laws and policies that more evidence would actually change the minds of leaders? And that's what I'm saying. I think we need to start thinking much more outside of the clinical and the HIV or even the health space, and much more playing the party in the political space. I would argue that we would need more robust civil society that it can actually ensure that we have leaders who can see all people as humans with equal rights to access to quality health, and leaders that deliberately design incentives in the system to ensure that that happens. We know that for key populations, that payer-led and payer-provided services are the most effective for engagement and for retention and for testing, right? In an ideal world, there would be more support and investment for community and payer-led services, which would directly address stigma, quality of services provided, and in turn start to close these gaps. And I want to make one second point here that we also have, I think we have a data problem. Well, up in your alley, Ambassador Birx, let me see if I tread carefully here. But I think it's just too easy for countries, and we've said this before, for countries to claim achieving HIV targets by masking the inequities in their subpopulations. And, I was looking at some UNAIDS data for 2022 EPI estimates. It was just in February 2022, looking at the progress towards the 95s in Zimbabwe. And they paint a very pretty picture for almost full achievement already, if you look at the adult populations. But once you start disaggregating and looking at gay men, other men who have sex with men, and transgender communities, you see a totally different and unequal picture. And as you said, this is the kind of granularity that we need to get the interventions in the right place. The nuance that comes from understanding why barriers exist, not just what barriers exist, and why people, for example, don't return to health clinics, or the data that shows that the time to get your viral load test to be used with a doctor is what counts for actual people on the ground, rather than the time it takes to get back to the clinic. And our data shows that user fees are still imposed through services that were free. And we need to get more demand side data for more calibrated interventions. I think you said this before, but I think sometimes we feel like we have the correct data, but we may be asking the correct question, or asking the same question, but you need a different answer from a different perspective. And so you may have the same indicator, but you need the recipient of care, the demand side perspective. And if you come with an attitude of, well, we know that already, well, then we're actually not going to learn anything new. I think this is more important now, given our global economic recession, where supposedly rich countries are even having austerity measures and small national health budgets are even smaller. We have put the little money that goes into health needs to go into the right place. And I would say that targeted community investments are the future.
Wow, that was terrific and powerful. And I think what I really learned over the last decade was the investment that the Global Fund made in community-led monitoring was incredibly powerful because it brought together both quantitative and qualitative data that gave us a lens that we couldn't see before. And I think it totally changed how PEPFAR invested in community-led monitoring. And I think, and that wouldn't have happened if someone hadn't started that investment and you could really see it. And I think, Solange, this is what you're really bringing up, that these new things have to be funded, but funded from the community lens. And I've always been struck by, if you look at rate of new infections prior to the war in Ukraine versus Russia, was a perfect example of how peer-led services trump country-led or host government-led services by a miraculous amount, because the Ukraine's new infections were going down and the Russians' new infections were going up. And the difference was not the amount of money invested, but how that money was invested. And I think you're talking about these smart investments in health, because money is limited. It's just so important. But then ensuring that we have community-led monitoring so we can interpret the data appropriately. And I think that's such a critical point. Micheal, though, the work on ensuring people have access, and you raised this, Solange, access to their viral load data, because that is actually the critical empowering piece for decision-making at the personal level. And I think U=U campaign and prevention access, and certainly you have been a strong voice in peer empowerment to understand testing, both diagnostic testing, but also monitoring within HIV. So you've really been at the community level. Can you give us some examples of how U=U has really empowered the community and the individuals, and how that can be taken to scale? And will the recent WHO guidance on a particular viral load level really help us advance better monitoring in countries to really define that U=U in a more clear and impactful way? Micheal.
Sure. Thank you, Ambassador. So good to see you, and so good to see you all. And I think, again, there's no better person that can speak about data more than you can. So thank you for all you've been doing and you've done around this work for a long time. I think, obviously, U=U is a clear and effective, simple way to convey the fact that a person living with HIV who is on antiretroviral therapy and whose virus is suppressed cannot transmit HIV to sexual partners. It is that simple. But as we know, it has not been that simple to implement. And the data and the science has proven that it is that simple, but I think the world and the field has struggled in implementing. I think you spoke about it earlier on about why, we create policies, but actually those policies live in shells. And at PAC, our goal has always been to make sure we empower our community members so that they feel empowered to take this message to their doctors, to their healthcare centers, and tell their doctors that I want to know my viral load number. I want to know if I'm virally suppressed. Tell me if I'm virally suppressed, because that's a huge motivation to stay on treatment. And that's why it's so critical. And we are so grateful for WHO for this guideline, because it's going to help the field understand what does it mean to be virally suppressed, and what does your number need to be, and how can it help you transform the way you see yourself as a PL-HIV person. So I think, again, just going back briefly, and why the U=U such a transformative message, right? Because obviously it improves the quality of life for people living with HIV and reduces stigma. I think that stigma part is so critical. As someone living with HIV myself, and as a gay man, and having to deal with double stigma for living with HIV, but also as a gay person. So I have had to deal with those stigma issues. But having the fact that you can tell your partner that you cannot transmit HIV sexually, that you can actually have kids, that message is so transformative for everyone everywhere. And it's so important that we give the information to people so they can use that message for their healthcare, for themselves. But also, it's not just for themselves, it's actually for the field, because we know that if people are undetectable, if virally suppressed, they cannot transmit HIV. And what does that mean? It means we can reduce new infections. So it's not just a personal benefit, it actually leads to the way of any epidemic. So I think that's what we've not actually grasped. So at PAC, what we've been doing the last couple of years is, yes, we want to share the message of U equals U to individuals, but actually it's more than that. We know if we can get community members virally suppressed, new HIV infections are not coming from the sky, they are coming from somewhere. So if people who are living with HIV have their quality of life, are virally suppressed, they cannot transmit HIV.
Micheal, such a critical point. And I think what's always struck me about HIV and the work there is the community is always ahead of the physicians and nurses and policymakers. And I think, I know it must be incredibly frustrating to people from the community, are like, we've been pushing this ball up that huge stuff for all this time. But I think, part of it is not measuring the right things at the programmatic level. And, what is the right thing? Well, it's as you described. The right thing is, does that client know does his or her viral load? And do they know what that means for their life? And I think that gap is still not being addressed at the program level. And we have to treat that it's a programmatic failure if the client doesn't have those two pieces of information, both their viral load and the impact that viral load has on their life. And I think that is such a critical piece. And I'm hoping, so let me pose the next question, and we're going to go in reverse order. So Micheal, you're going to be up again. So when you look about the last 3 years and what the health systems have gone through, and UNAIDS report and WHO acknowledgement of this issue of 70% of the new infections in a health system that often didn't serve that 70% of the new infections, what did you see over the last 3 years that gave you hope in COVID and HIV, twin pandemics, and things that worked that you didn't think would work? And then what really gives you pause about the one thing that you think was severely impacted in the HIV response that, as UNAIDS has really alerted that we need to get back on track? So Micheal, from your standpoint on the ground, what surprised you as good and what surprised you as really bad that needs to be immediately addressed?
Thank you. And one thing I would just add is, I think there would be no COVID response if it wasn't for PLHIV and key populations and CS organizations on the ground. I think that's just been so clear. If those infrastructures wasn't in places across the world, there would be no COVID response. And but I think in doing that, we've lost a lot of investment in the community because they've had to stretch themselves to respond to their communities and to immediately adapt the way they respond so that they can sort of provide support for COVID response. And they've lost a lot of staff members. There's a lot of funding and a lot of structures in place due to their response to COVID. So I think that's one critical aspect, because in the last 3 years, we've seen a lot of community-based organizations, either that lost staff members to COVID or that lost funding that is no more in place, are struggling now to sort of continue to provide services that they normally provided before. Their offices are not the same anymore. And sort of, again, what that has led to, we've seen reduction in people who have enrolled in HIV medication, like who have enrolled in treatment, and they're not coming back to continue their treatment. And they've been lost to care, quote unquote. So these people that have been lost to follow-up, we can't find them anymore because, again, we've lost staff members. The funding is not the same anymore. And now, due to COVID, the organizations that were in place in these communities are no longer as funded or have the same capacity to reach people they reached before.
Micheal, such a critical. You raised two. I think incredibly key points in it. One is, and I've been trying to say this, but I think people just roll their eyes and say, okay, yeah, Deb. I like, there wouldn't have been any ability to diagnose COVID if there hadn't been HIV. None of those machines would have been there without HIV and HIV-TB. None of them. And none of the laboratory personnel, none of the community groups that were critical in outreach and knowledge transfer, which was so critical. I think the other piece that you raise is you're absolutely right. When people get stressed and they're trying to serve clients, the first thing to go is data and data transcription. We see that all over the world. And I think that is such an essential point. And the third point that you make, and I'm hoping that we really make this at all levels and that we have HIV people sitting around the table in these pandemic preparedness plans. Because what I keep saying in the United States is stop planning for a pandemic. We have one. Let's address that one. And if we put those structures in place to address that one successfully, we'll have the structures that we need to address the new one. I mean, it's just this theoretic pandemic preparedness has never worked. I mean, the United States spent 20 years planning for a pandemic. And none of those plans worked because it didn't depend on testing. As we all know, in HIV is a gateway. So I always keep saying, if you can respond to HIV, TB, and malaria and the current COVID-19 pandemic successfully, and you treat every new infection and you treat every hospitalization and you treat every death as a failure of programming and you fix it, then you'll be ready for the next pandemic rather than spending money on theoretic preparedness rather than actual community engagement that supports a system. So Micheal, thank you for raising those issues because I think it's really the crux of what I hope comes out of World AIDS Day, because the HIV groups bore the brunt of the COVID response, yet haven't been reimbursed and further supported for the incredible work that they did. Solange, how do you look at this from your perspective of knowing Asia and Africa so well?
Yeah, I think Micheal said quite a lot of what I was going to say, which I'm happy that he raised the same points. I don't think in a pleasant way, I wasn't really surprised, but I was reassured that, the future is community-led, right? The HIV-derived health infrastructure and the community architecture was at the front line of the COVID response globally. I don't think anywhere I could say that that was not the case. We saw pair workers, community innovations, like for hand washing, very concrete things. And we had, normative agencies asking organizations like ITPC and our partners, what was going on? What are you seeing? What are you hearing? Really being the ears and the eyes on the ground, and community was able to rise to that challenge. I also was very happy to see multi-month dispensing, which we had been begging for forever. Or maybe you can do that now. Maybe you can put more than a month in someone's hand. And I saw that really increase. So lots of more self-testing, at-home methadone programs, really highlighting again the importance of treatment education and health education as those things were rolled out. But really just going back to that point about autonomy, like people, if they get the correct kind of information, can actually take care of their health. And there doesn't have to this supervisory role of the doctor and the clinician and seeing me every 5 minutes is really not necessary. So I think we started to see a trend and a move in that direction. So the community rising up and the community data, community insights, really being able to help with the COVID response and HIV. But on the flip side, everything was COVID, 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 COVID. I mean, literally, that's one of the quotes from one of our qualitative interviews. The lady said, well, what do I have to say? It's just COVID, 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 when we asked her what was happening with HIV. And I think we have some of those unintended consequences. We talked already about the machines being co-opted for that should have been used for viral load, now being used for COVID testing. And, there are also unintended consequences such as like, the social distancing and meaning to line up outside, very practical things when you haven't disclosed your status and you're like, oh, I see so-and-so on the street and therefore they're lining up. And so you have confidentiality issues, and then you want to know why people are not coming back. And we know that many of our new initiations are not, treatment naive. They're actually people who were lost in the system and just not coming back. And so I think that was, really important to note. The issue in Kenya still bothers me. I mean, they're still having issues with commodities, and the idea, and Michael's here talking about U equals U is theory if you really can't get a viral load test and you can't get your results. PrEP is a theory if you can't do a basic HIV test, and these things were expired and we're still having commodities issues. And so I think it's time to now regain what we've lost, and we need to realize that we're dealing with two things and you have to deal with both.
I think, to my mind, when high income countries became under threat, it was very difficult for middle and low income countries to get PPE, to get tests, the whole piece of the global supply chain fell apart based on ability to pay. So getting the struggle that I had to get PPE gloves into Africa, it was just phenomenal. In the end, I did something I wasn't supposed to do, but that's my job. And I just said, we're not going to buy American. We're just going to find it anywhere, and we're going to get it to sub-Saharan Africa, because we can't have everybody at risk. But I think, to me, that opened up a giant chasm, where we have focused a lot on human resources for health, and we kind of just said, oh, the supply chain. But I think the supply chain failed us. It failed us globally, but it failed us particularly in medium and low income countries, and particularly vulnerable populations, because there may have been well-off individuals who could get an HIV test or a COVID test or viral load monitoring, but not the average community member. And I think that you're absolutely right. The fragility of our response in that global context became really evident in who was left behind. And it was clear. And I really thank you for raising that, because I do believe there's a fragility in who was left behind. And I think I worry all the time that these COVID plans aren't going to resolve. these pandemic response plans are not going to have tangible indicators. To me, tangible indicators are, does every community member get an HIV test that wants one? Do they know the results? Do they have access to prevention and treatment services? And then do they have access to viral load monitoring? And does it get to them? These are kind of like fundamental, simple pieces. But if it isn't working in HIV, it's not going to work in COVID. And I think what COVID has shown us is that all respiratory diseases look alike. So if you want to know what's new, you've got to diagnose what's there, which means that you really have to have access to communities and clients. And I think that piece, that moving from a theoretic plan to an actual on the ground implementation, is still too vague, I think, in all of these response plans. And I think what you bring to the table is clarity. You don't need to have COVID data. Just let's see how we failed in getting viral load back to the clients. Or getting 3 months meds. This is really, we have simple indicators. And I think finally, with your community-led monitoring data, I think too many people focus on an absolute number, when what is really important is the trend lines. Are we bringing back more individuals that were lost? What are their age groups? Who are we still missing? Those trend lines really tell us, are our programs working or not? Data can always be missing. It's so imperfect. So I'm not sure an 85 is different than 105. But I know if I've gone from 85 to 105, it's vastly different than going from 105 to 85. And I think those kinds of pieces just are not understood when people want to just focus on a number rather than the directionality of that number. So, Regan, how are we going to measure this? How are we going to make sure that we're making progress? Have you developed new indicators that communities can measure so that we can really look at the programs and if they're having the impact that we need them to have?
Well, thanks. And actually, Solange made so many great points, and some I was going to make about the importance of this community-led monitoring work, which is still, we need to refine it and develop ways to get it relayed to the policymakers and to help us shape the programmatic stuff in a different way. I think, so the answer is we need to connect those dots more than we do. And I think just to emphasize 3 things about that. One, that real-time, real-life intelligence from the ground has always been, and Jeff, you said it, it's like we know on the ground where the problems are and what the solutions are far faster than we can ever make policies to fix them. And we need to make that, instantaneous relay of intelligence to people who are doing the work. And we saw it happen in Ukraine, right? We saw, the peer-led systems and the multi-month dispensing work so well, proving that we don't necessarily always need a formal health system, and that peer-to-peer stuff does often work better. And the point that you made, Solange, too, about trusting people, and which goes back to the very early conversations around HIV. Can Africans tell time? Can they take a pill at right intervals? It's sort of insulting as a person living with HIV that we think we need this heavy sort of supervision. And I've often thought that maybe people who are newly exposed to HIV or newly connected to care might need extra time and attention, but certainly someone like myself who's been living with the disease for 2.5 decades can use fewer resources and can actually be part of the solution, right? How can I, and people like me, like Michael's doing and others, help people understand what we're living with and also make the case as advocates? Because I think coming back to this intersection of data and policy and the whole conversation we're having, you're right, it doesn't make any difference unless we can implement these things and quickly, right? And I think when I look at COVID and some of the areas where things went well for HIV, it was shocking and in a good way how we could keep the systems together and how we could learn and adapt and save lives even in the most threatening and difficult of circumstances. So we just proved we can do it. Now, how do we do that at scale? And it's taking data like you have, Solange, and making sure that we also look at the data in the UNAIDS report and disaggregate it and tell the true story, so that we're not masking real problems because we're looking at numbers that are aggregated or general. And I think we've done that increasingly. We've looked at more granular data. We have looked at identifying who's really at risk, but it's these real life things. I remember this was a long time ago, but I was in Africa talking to women about the female condom and asking them why they weren't using it or what they felt about it. And this woman came up to me and she said, she had a shovel and she said, come with me. And we went outside and she said, try to dig a hole. And the ground was like cement. And she's like, where am I going to put this thing? She's like, I think it's a good thing. I might use it, but I can't get rid of it. And I was like, oh my gosh, an aspect of it that I had never even considered. So I think really understanding the real world implementation of this. And then I wanted to come back to the 2 points Michael made. One was on the value of the viral load test and knowing your status, having that goal of knowing that you're non-infectious and what that does to your own self-stigmatization. I remember feeling wildly different about myself when I knew that I could not infect anybody. I would never have infected anybody, but just knowing that biologically I could move through my home where I lived with my family, or hold my sister's baby and give my sister's child a bath, or, double dip my French fries in someone's ketchup without ever thinking about it, changed my life. And I think when I'm talking to people who are thinking about being in my life or just trying to help people be comfortable with HIV, I say, we're some of the safest people to be around. We know what we have, we're treated for it, and we're tested all the time for everything else. And gosh, we probably don't want to get anything else. So I think it's a powerful message both to the world, but also it helps people living with HIV recover some of that personal dignity and strip away the self-stigmatization that happens as well. And that, of course, then leads to lower rates of infection. And I appreciate your point there. And then lastly, on the financing, I agree. We've gone around in circles on this for a long time, and UNAIDS is about to lead a conversation with some partners in Washington to think about financing beyond ODA and to look at the bigger spaces You know, what are we doing with the reallocation of special drawing rights at the World Bank? What are we doing with debt reduction? What are, you know, we've talked about these in theory over the years, but now how do we actually move the needle so that we can get some of those releases in the economic system? Because we can't just go hunt in a fresh hunting ground and then battle other people for the same money. We have to figure out how we can make all of the money work. And finally, I just think, you know, Ambassador, your point about investing in these systems that we already have and perfecting them so that we can, we don't need to reinvent the wheel. It's so simple and so obvious, but I don't think enough people understand what we have built through HIV and the value of it globally and how we should just continue to invest in it. So final point, find the money and put it on the community level and solve the problems. When, you know, when people say, well, we can't fund small NGOs or we can't fund small community-led, you know, projects on the ground because figure it out in the system, you know, find a way to get the money to them and help them if they can't do the reporting or there are issues with running the money through them. And I think that's something that we can all work to change.
Regan, thank you for raising that. I'm stunned how we always create our own roadblocks by building on our own perceptions and assumptions about things. I mean, we self-stop doing things because we say, oh, this will never work, or we can't do that, or that's, I remember when people said to me, no hospital will report the new admissions, they're too busy. And, you know, I'm like, did you ask them? So I went and asked the 6,000 hospitals. I said, would you report new admissions for COVID? Because I need to really get you what you need. And I can't based on, you know, who's been in the hospital for 100 days. I need to know who's newly admitted. I had 93% reporting that first week. So I think we sometimes hold ourselves back by saying no one will do this. And I think our real challenge is every time we hear that, and I think WHO and UNAIDS is so critical to this, is every time we hear that from a programmer or a donor, is we need to say, did you try? What have you done to try? So Meg, please.
Well, there's been so much territory covered here, and I'm not even sure I can recall the first question, but I wanted to build on a couple of things that were said about the COVID, what surprised me with the COVID pandemic, and then what's happened since. And I think building on that, I was very surprised that it took us a while at the global level to understand what resources were available around the world. And that, I think, is a failing of communication across departments, across teams, across ministries of health, etc. That it did take a while for people to know how much was there in terms of viral load capacity in countries, and that this could be utilized in low and middle income countries. I was really surprised and still remain surprised now with the monkeypox outbreak, that it takes a long time to move things to low and middle income countries, and that we're not thinking about this from the get-go, and that this isn't worked into our plans from the start. And with monkeypox it was, but it's just taken us a longer time than I would have expected for us to make sure that there's access to testing, treatments, and vaccines. I was surprised as well about both the positive and the negatives of what is happening on the internet. You know, so there was so much communication. We were inundated with communication. Excellent communication. This supported what we were doing in terms of all the mentions of the differentiated models of care, the self-testing, the self-care, the virtual visits for HIV, also about the information about COVID, what to do, where to get them. But then at the same level, it has created, I guess, a global community that believes they know what's good and what's bad, and that there's a constant need to bring forward evidence and messages around science. And I think that's been surprising to organizations like WHO and others, where now every time our messages also has to be, how do we make sure science is really well understood and that everybody can understand what we're saying? because the infodemic was really, I think, very surprising, and it has led to us still having problems, I would say, in having the world fully vaccinated for COVID. We still, in Africa, we would like to see 70% of all African nations being able to vaccinate for COVID, but we're not there yet. And I would say that that is something that we would want everyone with HIV to have the opportunity to have access to a vaccine. And so I think also from the global health architecture around pandemic preparedness, as you're mentioning and alluding to, Ambassador, we have to work into that architecture the essential health services and maintenance of that all the work that we've done around HIV, around TB, around NCDs. And I think sometimes the loudest voice gets the biggest seat at the table for those actions. And we need to have all of those essential health services well articulated in any pandemic preparedness. And it's not just to say there is a base of data collection, supply chain, et cetera, that can be used, but that we have to maintain these services and we can't forget about them. And we can't allow more deaths to happen because of the essentials visits missed than actual, say, COVID pandemic deaths. I mean, and that's what happened. We had many more global deaths related to the fact that people didn't get to their HIV services or their cancer services or their screening than actually to COVID. And so we have to somehow be able to do both of these and do both of them well. And I think that's going to have to be worked into all of these pandemic tools, and ensuring that community as well is maintained at the table as these are negotiated. And that would be one thing that I think is also difficult probably for community. We've talked a lot about how community-led services, there's so much to be learned there, but that's also being stretched. You're being stretched because you're coming to the table for monkeypox, you're coming to the table for COVID, you're trying to keep the voice going on TB as well as HIV. And that's difficult to do. And I think it stretches people as they look forward. It's like, where do you put your energy? And how do we make sure that those messages are well, I guess, reflected back from all public health groups, ministries of health, et cetera, so that it's not just dependent on somebody always coming and saying, look, you've forgotten this, or bring us to the table. So there were so many excellent things discussed. I would have to say, we haven't figured it out. And I think we're going to have to make sure that we're at the table for all of these pandemic discussions. And community-based community programs, so important, but it can get lost if we're not there and we're not having that discussion. And just see what happened with monkeypox. We were able to respond to monkeypox because of communities, right? That's what's happened. They're the ones leading the research, they're the ones leading the communication, everything. And I think our traditional response is there, but it's slowly moving through its paces. And that's something that we won't have time for. And that's where we have to say, okay, we've shown that we haven't learned all the lessons we need to for the next pandemic when it comes. So I'll stop there. Thanks.
Meg, I think you raised such an important point that both Solange, Regan, and Micheal also raised, is your ability to show that you are empowering communities to know their status, to have access to testing, that they have access then to both prevention and treatment services, and then they have access to the monitoring that they need. That's independent of the infectious agent. And I think what we ought to go back and look at is, in each of those areas in the COVID response, where did we fail? Because I think it's where we failed early on in HIV, and we working together to fix those things. But, the problem was not, and the problem today is not vaccines in country. The problem is vaccine in arms. The problem is not Paxlovid in a pharmacy. The problem is COVID testing and access to Paxlovid at the community. And I think if we, and because I think this is one place where the high income, middle income, low income countries all share the same issues, is that disconnect between having a tool and having a tool that's actually available and utilizable at the community level. And I am still shocked at the number of people who just say it's there. And I'm like, what do you mean it's there? I mean, it's not there if people don't know it's there and they don't know how to use it. So I think what I'm hoping that Global Fund or Global Fund PEPFAR can go back and look at the COVID response in the region and say, you know, objectively, this is where we had problems, and this is how the community has always responded to this and has an HIV and can bring that talent, because I think people don't understand that the solutions are already there. So let's move to key populations in our final minutes, because I think all of you have said that that's our biggest gap. It was our biggest gap 40 years ago. It's our biggest gap still. So we have not really been able to comprehensively bring prevention, testing, treatment, and monitoring to the groups most vulnerable, most marginalized, and most in need. I know, Meg, you talked about cities and what we can learn from London that are now at 0 infections. How can that information be translated to low and low income and middle income resource limited settings? How can we take those lessons learned and make it available immediately, not the decade it took us to bring treatment to Africa, but that knowledge base? What is it going to take? And I'm going to ask each of you, what can the WHO do? What can UNAIDS do? And what can the community do to really ensure that we're holding ourselves accountable to that translation and really mapping whether we're making progress day after day? Because it's a little bit disconcerting that we're really almost in the same place in not reaching the groups that we know we need to reach. So Meg, I'm going to start with you this time.
All right, well, thanks. And I think, you know, we're working on this very seriously, and I do believe that the examples that are coming out of London and some other cities can easily be transferable, meaning that it's taking the concept that Micheal was alluding to, that people who are on treatment know that their treatment will, when virally suppressed, means they are not going to be transmitting, and that's going to reduce the number of new infections. Secondly, making sure that we have available PrEP. I think in many ways, people are waiting for the new shiny innovation of long-acting injectable PrEP, which is great, and we know it's going to work well when it's available. It's not yet available, but these cities that have reduced new infections have been using oral PrEP in combination with treatment. So as well as regular testing and self-testing, so that people are aware and are coming into services. Services have to be much more accessible. And I think one of the things we have been talking about is reducing stigma and discrimination. And I do think that there are a lot of tools, there are a lot of programs, there are a lot of approaches to reducing stigma and discrimination, whether it's self-stigma, but also stigma within the health care setting and in facilities. We have to actually, and this is something that WHO is trying to take on and needs the help. We've spent 20, 30 years looking at reducing stigma and discrimination, yet it still is an issue in many places. So what is it that we can do? Is it a training? Is it ongoing quality of care monitoring? Is it changing healthcare workers in different settings? Is it, you know, the community-led monitoring where there's an immediate report so that the activities in a setting of a healthcare setting is reported back that this is not high quality care or there are issues. And I think that will help us to bring these models to other settings. And then again, I think we have to look at those countries who are saying they're at 95, 95, 95, the countries that have really indicated that they're there. We've seen that with Botswana, for example, it can be incredibly motivating and a positive political message to say that they're on the path to elimination for mother-to-child transmission of HIV and syphilis. And now we're adding hepatitis B there. But to be honest, that could be a way to get certain countries, certain cities to say, we want zero new infections, or we believe we can get on the path to elimination. And that can become a big political feedback loop to say, now you're making progress, keep on that path. And we've seen it for hepatitis, for example. We don't know how many countries want us to certify them for eliminating hepatitis C. That's a program where we have a cure. I think we need to do the same for HIV, and it may be by districts, it may be by cities, it may be by populations, but that is what I believe we're going to need to do over and over again to reach our to actually reach our 2030 targets. And so I think with key populations, we just need to ensure also, all of us, that we're doing our best to reduce any kind of challenges or difficulty in language. And we've seen that there has been a real how do we say, a very polarized set of countries right now. And what we've learned in those polarized countries is that we need to be able to communicate in a way so that people still get the services that they need. And we need to be able to ensure that those services are happening. And that's something that WHO is taking on in all of our regions. So it's not just in Africa, but it's across. We have to do the same level of work in our Eastern Mediterranean, our Southeast Asian countries, and our Eastern European countries, and find champions where we can who want to drive that agenda, so that everyone has equal access, and that we're talking about stigma and discrimination in real ways, so that there are changes there. So from our point of view, we want to see this happening in the next 5 years, 8 years. And so every 2 years, I think we're going to have to come back and say, are we doing well on this? Where are the countries who are really shining? What can we do to ensure that they have recognition for the amount of work and the amount of success that they've had in getting to zero in certain areas or in certain populations?
Thank you, Meg. I think sometimes we talk about all the good, but sometimes we have to just admit we failed. And I think sometimes by saying, how do we, work with health service delivery when it's clear that they're not going to change, is to say, okay, we need a different model for individuals. And I think being very clear about, now that we're very clear about the risk of new infections, being very clear that whatever we're doing is failing, and we're getting further behind. And so the systems we have put in place, the way we've delivered testing, the way we've delivered prevention, the way we've delivered treatment, the way we've delivered viral load monitoring for certain populations has failed. Regan.
Well, great. I think, at UNAIDS, we've recently reconfigured ourselves to have to form a new branch focused on policy, advocacy, and knowledge. And the main focus there is to do, as we've been talking about, get these policies off the shelf and mobilize politically so that we can change the things that are keeping us from making progress. So I think thinking very clearly with our partners on the ground and our co-sponsors and others about what can we now do? We understand the problem really well. And it's been said in various moments in this discussion, we're really good at identifying the problem. Maybe we need to refine the data a little bit, but now how do we get on with it? So, the framing of our World AIDS Day messaging this year is equalize, but what does that mean if you're a political leader? And I think we have a lot of education that we need to do. We have new political leaders in many countries around the world, including in the US, which is one of the largest donors to the global AIDS response. Many of the people who started PEPFAR and Global Fund have retired and moved on. And I think we have a light bench of people coming up through the ranks who understand this work well. And I think we need to do some of the things that we did at the beginning, which is both putting people on the ground with people whose lives hang in the balance of their political decisions, and helping them understand that these laws, these policies, these funding decisions are made by human beings, by people, by groups of people who have their own agendas politically and their own agendas collectively politically. But we did a great job influencing them with HIV in the early stages. And I think we need to bring back some of the original playbook moves. Because again, we have fresh people. We who work in the field tend to think this is all well understood, but again, we have new partners. I think, also helping everybody understand that these gender inequalities and harmful gender norms are really bad for any epidemic, not just AIDS, for any epidemic. And that gender-based violence increases women's vulnerability to HIV, but we saw, in COVID, incidents of GBV go up, and we saw people who were transgender and gay or men who have sex with men being criminalized and targeted in lockdowns and COVID. So we really need to reinforce the human rights work that we're doing and make sure that everybody is well protected and that the environments are enabling and safe for people to just save their own lives. I think it's one of those things that is it's so obvious. We also talk about the need to change toxic masculinity, which drives a lot of different things, including men's own willingness to access the healthcare or take care of their partners or disclose information. So I think there's an educational arc here that needs to continue, but also be redoubled. And it's, listening to both you, Ambassador, and you, Meg, it's always that hard balance between wanting to reward the positive and say that we can do this, and also be honest about where we're failing and really prod those people. And that's the hardest part in some ways for me about messaging around this particular disease, is that we have made unthinkable progress, and there are, countries and communities and groups of people doing things that no one could ever imagine and having success that's incredible. And then countries that completely ignore their pandemic or epidemic or lie about the data. So we can't end a pandemic until we access everybody, and we know this to be true. It's biologically a fact. And so how do we move? And for me, I think it's UNAIDS. We have a lot of renewed focus on political advocacy and influencing and finally changing the culture in which the politicians and decision makers live. And a lot of that comes back to some of the things you were saying, Solange and Micheal, about getting those perspectives of the people who we're serving and who are living through this, connecting them to the decision makers, not just having a seat at the table, but really giving them the ability to negotiate with them. And as you are all saying, shape the future of the thinking on pandemics. If you want to learn how to stop a pandemic, go to the people who've been doing it for 40 years. So.
Thank you, Regan. I think that last sentence is somehow, when you take the policymakers and the decision makers into the field, they have to understand that last sentence, because I think that's sustainable funding that we need for the HIV community has to come out of that preparedness fund. Because you can't be theoretically prepared. You need to be actually prepared. And that means you actually have to be providing services. So this to me has never been theoretic. I know it's never been theoretic to any of you all, but to many people, it is theoretic. It's words on paper rather than actions on the ground. And I think really helping people understand that is so crucial. Solange.
There's the no-do gap. We know what to do, but we don't do it. You can take that at the global leader level, at the national level, and you can do that at the clinical level. And I try to understand, why does that gap persist? And I come back specifically on HIV that shines a light on it. It's a moralized issue. Somehow this disease is not like, your regular old hypertension sort of situation. Like, there is something here that says we're just not going to deal with those groups of people. And I come back to the fact that we need to speak truth to ourselves, and we need to get more politically savvy and start to step outside of the regular participants in our discussion and start thinking how we can pull the political levers. And I do think that with COVID, there was a global scale example of what misinformation could look like, and how even information at a local level, if not messaged accurately for communities, makes no sense. So when you say, if you have comorbidities, I'm sorry, what does that mean to the regular man on the street? Even I am like, okay, which of the comorbidities, and or what is a comorbidity? And then you have literal language translation that has to go through, and then you can understand why people are confused and why there wasn't uptake of certain therapeutics or vaccines or whatever it is. If you're thinking about monkeypox or HIV, PrEP, anything, putting it out there, as you say, is not any reason for why people will get it. Look, I think about the last treatment access survey that ITPC did, and I was expecting lots of things about viral load, and you kind of anticipate what the survey is going to tell you, but the most pervasive issue was stigma. And so there's no way that we could ignore that. And I think that we have to remember that community-led monitoring or community interventions, but I am focusing on monitoring because I think it is really important, is a model that can be applied to anything. It could be for voter fraud. It's for what communities see as a problem, and they develop the indicators for those pain points and track that over time. And so I think it's really important to know that community-led monitoring not only shines a light on an issue, but it can also bring solutions to the table. We know what to do because of the lived experiences as communities being able to say what the solutions are. So when you apply that in the stigma context and you think about key populations, we know that you get a certain nuance as who asks the question number one gives you a different response. When I ask my kids, am I the best mother? They say yes. And when they ask their peers, they're like, maybe there's a different answer comes through. So I think we really need to interrogate whether or not we are applying community-led monitoring to the places where we think we can get the most new information, the nuance, the insight that can actually help us to target this $1 that we're now trying to stretch. I don't think anything here is surprising. Those that were struggling before as key populations are struggling even more now that we're in a post-COVID kind of world. So I am not super hopeful that we're going to change that problem unless we shine a light on the laws, the policies, the norms, and that's going to come from very local data for local change. And community-led monitoring can get you to that kind of information. Yeah, I think I'll pause there. Thanks.
Really important points, because I love the way you say we know what to do, we just don't do it. I've seen that in the United States, where as public health officials, people are blaming it on the client rather than fixing the problem. And I think we've seen that with key populations now for decades. We're seeing that now in the United States, where people are saying, it's how you voted, and because you voted, you're doing worse. Well, no, that's our job as public health officials. It's not to point out the problem, it's to fix the problem. And I think that translation of pointing out the problem to fixing the problem and being honest of whether we fixed it or not whether we felt good that we tried to fix it, but we actually fixed it. I do believe that that's where the intersection of community-led monitoring is. And I think we're still not really there in making that happen in a real way, rather than, it's a nice to have. What was shocking to me is, as you remember, there was this process called PFIPS and in PEPFAR, and an issue of decreasing money in upper middle income countries. What was very interesting to me is the very first thing to go was the community health workers and the community outreach groups and the peer-led. Very first thing to go. So we have an evidence base of what's valued when money gets tight. And I think the World Bank, the funders, PEPFAR, Global Fund, the policymakers, WHO, the Strategic Alliance and Data Group of UNAIDS, they need to give voice to this. It needs to be very clear. We know what decisions countries will make about their health system when financing gets tight. And I think we just have to state that and then track that, as well as what we're doing in key populations, is to say, you know, how many community health workers are there? How many community-led groups are there? What is the investment in community-led monitoring? And the funders need to be holding countries to account, because it shocked me that it was the very first thing to go, which really, I guess, gives you insight into what is valued. Micheal.
Yeah, thank you. Just so much to this conversation. And I just wanted to add, I think obviously in the last couple of years and maybe the last decade, we've been speaking about leaving no one behind, and it's become a reoccurring theme. And actually, we are constantly leaving key populations behind. It's just become something we just have to say because we need to say it to save face. And we just say, oh my God, leave no key populations behind.
Micheal, I really appreciate your comments. About a couple of years ago, I was on a Zoom and one of the activists said, I'm just so tired of repeating the same things and things not happening. And I think, you know, having been in the position of running a program, it's very difficult to admit to yourself that your program is failing people, because you don't want to believe that. And I think we have to, and I hate to put this always on to the advocates, but you're going to have to be that stark and say, okay, you made this promise 12 months ago. Let me just show you nothing has happened. No one additional has been served. We're still missing these groups. It's still, because those are the hard conversations that we had to have behind closed doors with ministers of health. I'm sure you know, when we would all get together, there was the public sessions, but then there were very private sections that said, you know, what are you gonna do about this? Because it's bad. I mean, and you got to really be that honest that it's not working. And I think, I know it's hard to challenge people and say it's not working, but that's what we need to hear. Because in the end, we have to make it work for everybody. And if it's not working for everybody, that's on us, the people who have the money, the people who can drive policy with that money. That is really on us. And I think there's a huge moral responsibility when you are in charge of programmatic money, that you recognize that it's more than what you, as you described, it's more than new infections. It's quality of life. It's how people live. It's using your funds in a moral and ethical way to address barriers that exist for 40 years and shouldn't have been there, but it is your job. I mean, yes, you could get there going around a circuitous route perhaps, but then it's not a lasting change that really serves the community. And I think that's always hard for program managers, but you know, preserving the Dreams funding and the Key Population Investment Fund in a very different administration where that wasn't probably part of their core values is what we can do together when we work together. And I think there should never be an excuse that people can say, oh, the administration, because it's the program's job to figure that out. Because administrations change and investments change and donors change, but you have to really continue to push that program. And I think I was always grateful that the community trusted me enough to be honest. So Micheal, starting with you, one policy or one investment change?
One policy will be, I'm looking forward to seeing how WHO can help us provide more direct link about structural interventions and link to incidence reductions. I think we have the sort of implementation policy for key populations document, the mismeans and the transgender one. I think we really need the direct link about how, because we see this as a stigma reduction, it's a human rights issue, but actually there's linked to incidence reductions. So I think, you know, if WHO can help us provide a guidance to government and to us as advocates to use as a tool to sort of towards PEPFAR and Global Fund to say, actually investing in this can reduce new infections. That's a policy issue. But secondly, I'm really looking for to see, again, reinvesting in PLHIV is so key. And it's transformative in terms of U equals U, because you cannot achieve that first U if you don't get people on treatment. And sort of getting people on treatment requires investment in the field and investment in treatment literacy. That's so important. Also looking forward to the new WHO guidelines on viral suppression.
Great. Solange.
Yeah, I think I would think about this from a donor investment side. I really would want to see a shift of donor investments from like handouts and derivatives of aid to be real investment in communities beyond demand creation and advocacy and a little project here and there. I think in AIDS 2020, there was a lot of questions about if we had to do it all over again, what would we do differently and what could we engage in? And the answer was resounding. And even from this web discussion today, engage communities.
Terrific. Regan.
Obviously, we need to fund the community-led work and the work with communities directly, but I think we need to invest in work that actually moves the laws and the policies in a different direction. And that's partially advocacy at the very highest level. And it's education, it's taking this data and showing people, showing leaders that if they don't do this work that they don't want to do, if they don't, to Michael's point, do something different with key populations and change the way they think about the human beings who are in the key populations, they're never going to end their pandemics. And they are, you've used the word moral many times, Solange, and it's true. There's a responsibility that comes with leadership and this opportunity that we have to stop people from suffering and from dying when we have the tools to prevent those things. And it was one thing when we didn't have them. It's another thing, now that we have both the ability to entirely prevent every new infection and to keep everybody from developing AIDS. So I think it's very high level work that we need to invest in. That's a combination of, the partners on this call and other partners with the communities going to leaders and saying, we need to do this because this is, we've swirled for years. This is it. We are at that point where the stuff that nobody wants to do is the stuff that we have to do to end it. And we have to do a better job helping people understand that if they don't do that, these things will go on forever and will continue to threaten everybody, not just people in key populations. They're threatening key populations partners, which is not okay. And they're threatening the world at large. And even the people themselves are making decisions. So we have to keep making those links and helping them understand that key populations do not live in a bubble. They live in the real world. And also to I think, reinforce that moral obligation. And I think finally the non-negotiable nature of pandemics. They don't go away, they get worse, and you can try to ignore them. You can punt them to the next, administration or parliamentary group. But really, you when you have a moment like you have with HIV, you have to seize it. You have to double down, because you will then also free up your resources for the things that are coming down the pike, and we know they're coming. So it's incredibly irresponsible to dilly-dally in a moment when you have the capacity to capture the end line there. So I think it's about advocacy at the highest levels.
Meg.
Yeah, thank you. I think from WHO's perspective, the policy item we'd like to see is that our key populations in those 5 area of interventions are actually adopted and implemented and, put into practice at the CCMs, at the COP guidance, and at all the discussions that are happening for the next several years of funding. And all of those, and I think it would be excellent to be able to work with Micheal and others on if those guidelines and if those recommendations are put into place, which are pretty all-encompassing, that we can show that there's a shift in incidence. And we would love to be able to show that. For the investment as well, I think I always look at life a little bit more with the glass half filled than half empty. And sometimes I think about how we're always talking about the zero-sum game, that we don't have enough money. And I don't know if all of you have listened to what Paul Farmer was speaking, but it came back again and again with his death this past year, is that we're not asking enough. We're saying we have a limited ceiling on health investment. And it might be naive to say that we can grow that ceiling of health investment, but we should be able to do it. We've been able to do it when we have needed to do this for war, for security, And health is just as much of a security threat. So could we grow? Can we grow and not make this a zero-sum game where we have to compete with a limited ceiling of finances? And it may be one of those things I don't know how to effectuate, but perhaps people like Ambassador and others who are working at that high level can say, let's grow what we're going to put in. So if every Ministry of Health, Ministry of Finance could grow and commit a greater proportion of their GDP to health and to key populations to HIV, I think that would be something that could have huge effects, because many times we're just waiting for the PEPFAR funding, for the Global Fund funding. And I don't think as we look to the long term, we should be talking that way. We should be talking about what is the ministry, what is the country doing for its populations, and calling them out and asking them to grow the pot of money for health. So that would be my one wish.
So incredible points. Vibrant discussion. My really bottom line take home message is where Meg, where you started, where you said person-centered care. And it doesn't matter if that's access to testing, access to prevention, access to treatment, or access to viral load. What matters is that the person has that information. And I think we can chart where we're failing. And I guess I'm going to put out something kind of, I like to be provocative and a little bit wild. It's the way you push the envelope. But maybe we admit that our current approach of funding through the public sector is failing key populations, and move those resources to peer-led groups like they did in Ukraine. And I think we do have a clear evidence base from the fast track cities that those cities succeed when they move money from the public sector into the community funding and peer-led. And so I think the real call to action is, what is Global Fund and PEPFAR moving funds based on that need to community direct service delivery outside of the public sector, and just admit that it can't be done there. And I think we'll see that with other pandemics, that not everything can be done through the public sector or the current health system. And I think we've talked about community health systems and community health system strengthening, but I think HIV, which has always pushed the envelope, should push it now to say, 40 years in, I think we can admit we started with key populations. It's still our gap. We've tried it through the traditional health system strengthening, and now we need to say, we're going to take a different approach. And all of that money that we would have put towards key populations, we're moving it out of the public sector and into the community peer-led. And I think holding funders and policymakers to that shift. Remember, the government of Ukraine used to fund those directly themselves. It wasn't just all donor money. And I think if we want to change how people look at things, we have to drive that change and be part of driving that change. So thank you so much for your time today. I have so much respect for each of you, because you were willing to take the time to call out mistakes and say, you're not doing this well. And I think that's the best thing you can hope for as a program manager, that people believe you're going to listen and act, so they're willing to invest that effort. So thank you for investing that effort in me. Thank you for continuing to invest that effort into others, because the one thing about the HIV/AIDS field, I hope we can always be honest with each other. Thank you.
Thank you.
Thank you.